Hello, it's Mark Cooper from Australia, and what I want to do is give you a background about SGLT2 inhibitors. And initially I'll talk about kidney protection, but I will not talk about it in a lot of detail because I will leave this to the following speakers who will talk about the relationship between the heart and the kidney, and then an update on SGLT2 inhibitors in diabetic kidney disease. So when we talk about chronic kidney disease, it's very important to appreciate that chronic kidney disease means more than just end-stage kidney disease, dialysis and transplantation. We need to appreciate that chronic kidney disease is associated with an increased risk of cardiovascular events, as reflected in clinical trials as MACE, an increase in sudden death, and an increase in all-cause mortality. Furthermore, we are increasingly appreciating the close link between chronic kidney disease and heart failure, and also the increased risk of drug reactions, adverse side effects from different medications given to these people. Chronic kidney disease is a major epidemic. Probably occurs in up to 10% of the population, of which the majority, almost 90%, are not aware that they have chronic kidney disease. And we know that the major causes of chronic kidney disease worldwide are diabetes and hypertension. And chronic kidney disease is increasingly a major cause of death in the community. So for example, in 1990, it was number 24 in the world. In 2007, it was number 16. And probably in the next 20 years, it will go up to being the 5th commonest cause of death in the world, and will be about 2 places above diabetes, which is also an increasing cause of death. So the issue of diabetes and chronic kidney disease is an increasingly important clinical problem. Indeed, if we look at all the chronic kidney disease in the world, diabetes represents over 40% of chronic kidney disease. And in many parts of the world, particularly in Asia, it's now more than half all the people with end-stage kidney disease. So let's look at how we treat people with diabetic kidney disease. And we now consider multifactorial intervention as the mainstay of treatment. We focus on glucose control, blood pressure, particularly blockade of the renin-angiotensin-aldosterone system. We know that there is important evidence for weight loss and diet being useful. And finally, blood lipid lowering is very important, albeit mostly for reducing the associated cardiovascular rather than kidney disease. And we will hear more about that in the talk that follows mine. So let's look at the data for glucose lowering. And if we look at 2 of the major trials in type 2 diabetes, the ADVANCE trial on the left and the ACCORD trial on the right, you can see that with intensive glucose control, we do not see a very impressive effect on serum creatinine in the total population. However, the ADVANCE study did show if you aggressively treat people and follow them for at least 5 years, you will see at least a 50% reduction in cumulative end-stage kidney disease. We've been very fortunate to follow up these patients in the ADVANCE ON trial and have confirmed in the Zungas paper in the New England Journal this persistence of benefit of glucose lowering on end-stage kidney disease. The mainstay of treatment for preventing end-stage renal disease over the last 20 years is based on the seminal studies published almost 20 years ago with the renin-angiotensin blockers. And I show you here the data from the RENAL study with losartan, and there was similar data in the IDNT with irbesartan, showing for the first time a specific treatment could reduce the risk of end-stage kidney disease by more than 20%. But since that time, till very recently, there were no new treatments that showed renal protection and benefits. Now, a question that is often asked is, what is the benefit of diet and lifestyle? And in the Look Ahead study, you can see here that diet and lifestyle, although this was primarily a cardiovascular trial, was associated with some renal benefits. A modest decrease of about 20% in the number of people who end up with low GFR, less than 45 mils per minute, and a tendency, albeit not statistical, for a reduction in renal replacement therapy and doubling of serum creatinine. So I've shown you a range of treatments that might be helpful for diabetic kidney disease, but we know that we don't treat people in isolation. And so what, as I mentioned earlier, we need to look at the role of multifactorial intervention. So here in the STENO2 trial, which was performed more than 20 years ago, 7 to 8 years of intensive treatment at the end of the study, at the 8-year time point, showed no clear-cut benefit on GFR. But if you follow these people for another 13 years, we see a benefit. It's small but statistically significant. There was a benefit, a long-term legacy of early aggressive treatment in reducing the rate of decline in GFR. However, the effects on albuminuria were more transient. As you can see in the shaded left side, the blue area, during the active time of the study, there was a reduction in urinary albumin excretion. But over time, when patients returned to their normal treatment, urinary albumin ended up returning to the normal range. What about the new treatments? Well, we're very lucky that in the last decade, we've had a new group of glucose-lowering drugs. This includes GLP-1 receptor agonists and SGLT2 inhibitors. And this symposium will concentrate mostly on SGLT2 inhibitors, but I thought it would be a good opportunity to review some of the data we have with another exciting class of glucose-lowering drugs, the GLP-1 receptor agonists. And I show you here a meta-analysis from 5 trials that showed a benefit on renal endpoints, including change in macroalbuminuria. And you can see in particular the LEADER study and the more recent REWIND study have shown approximately a 20% reduction in renal endpoints, which was confirmed on the meta-analysis. If we look specifically at the most recently published study, the REWIND study with dulaglutide, you can see here that in particular there was a significant benefit in a greater than 40% or greater than 50% decline in eGFR. And this was also associated with some cardiovascular benefits, confirming the role of GLP-1 receptor agonists in cardiorenal syndromes, as seen in diabetes. But I think the real excitement has come from the SGLT2 inhibitors, where there have been a range of studies that initially focused on cardiovascular endpoints, but also included renal endpoints. So if we look at the range of studies that have been performed, you can see most of them are in the green area: the DECLARE study with dapagliflozin, CANVAS with canagliflozin, and the EMPA-REG outcome study with empagliflozin were predominantly in patients with preserved renal function, and most of them did not have albuminuria. By contrast, more recently, last year, we saw the results from the CREDENCE study, the first dedicated renal study, which was primarily in patients with reduced GFR and macroalbuminuria. And I will review very briefly the results of these studies, and we will hear more about them from the talk from Professor Vanna. So you can see here, this is a very nice analysis from the EMPA-REG study by Cherney, where he's looked at the patients with normoalbuminuria, microalbuminuria, and macroalbuminuria. And you can see more than 4,000 patients had normoalbuminuria, and there was a very modest effect on renal function preservation in the red line with empagliflozin versus placebo. This was even more dramatically seen in the microalbuminuric subjects, but the key finding was in the macroalbuminuric subjects, where if you look at the red dotted line, you see an acute reduction in GFR with empagliflozin, which then does not decline as fast compared to the placebo group. And indeed, this set of studies revealed the renoprotection of SGLT2 inhibitors. More recently, we have the very exciting results from the CREDENCE study presented in Melbourne last year at the International Society of Nephrology and published at the same time in the New England Journal of Medicine. And you can see here, what we can see is that there was the canagliflozin group, that's the blue line. There was a significant number over 3 to 4 years who developed either end-stage kidney disease, doubling of serum creatinine, or renal death. This was lower than in the placebo group. and this reduction was over 30% and confirmed the renal benefits of this class of drugs. Now, we are very fortunate that we've had a range of trials in this area, and I'm just going to show you a summary of the kidney outcomes of the randomized controlled trials. The top three were cardiovascular outcome trials where it was only an exploratory analysis of the renal work. And you can see in all three there's almost a 50% decline in these hard renal endpoints. In the dedicated kidney outcome study, there were consistent results again with an almost 34% reduction in end-stage renal events. In the recent dedicated heart failure outcome trial, we saw a consistent result, albeit it was not statistically significant because this was a heart failure trial and there were much fewer numbers of renal events. So if we look at a meta-analysis of the 4 studies that have been performed with SGLT2 inhibitors with detailed renal data, we see a very solid, consistent benefit, no heterogeneity, and a more than 40% reduction in the composite of loss of kidney function, end-stage renal disease, or death due to kidney disease. So we have very exciting data, but we have a lot more to learn. And we are very fortunate that we have 2 ongoing trials that focus on chronic kidney disease and indeed include patients with non-diabetic causes of chronic kidney disease. On the left, we have the DAPA-CKD study, which has closed early, about 6 months early, and there was an announcement in the 30th of March 2020 that the results are positive and therefore the study was finished early. On the right, we have the EMPA-Kidney study, which is very similar in design, although it initially did include a group of type 1 diabetic patients. They have similar inclusion criteria, similar primary endpoints. We will soon hear the results of the DAPA-CKD study, and the EMPA-Kidney study is ongoing. So finally, where are we with respect to all these treatments? Well, we know from the EASD, from the American Diabetes Association, and from renal organisations that there is increasing interest in these newer glucose-lowering drugs. So the management of diabetes now considers kidney disease as part of its treatment strategy. You can see here that if you have established cardiovascular disease, heart failure, or chronic kidney disease, this helps in determining the right drug. So if cardiovascular disease predominates, we would either use a GLP-1 receptor agonist or an SGLT2 inhibitor, 2 classes with proven cardiovascular benefit. However, if the patients have chronic kidney disease or heart failure, we would generally use an SGLT2 inhibitor. Thank you very much.